Chapter 33 is going to cover pediatric emergencies, covering the pediatric assessment. Pediatrics are broken up into a few different age categories. A neonate is essentially a baby who's brand new, just born up to 4 weeks of age. The infant is 1 month to 1 year, toddlers being 1 year to 3 years old, preschoolers being in the age range to be in preschool, 3 to 5 years, school age, meaning elementary, middle school years, 6 to 12, and adolescent, those high school years of 13 to 18. Those neonate and infant babies will have what is called fontanelles. These are the soft spots on top of the infant's head. As you can see in the picture here, in this area right here is going to be soft. And basically all that is that the child's head, the skull, is not completely formed yet. So the skull remains not intact, so when the baby's born, it allows that skull to shape to come out of the birth canal. So when you see these brand new babies and they got a cone head, that's why. It's those plates in the skull have been kind of compressed to make it easier to come out of the birth canal, and then it'll eventually go back into place. And within the first year of their life, those fontanelles will close up. Also noting with the head that the child's head is much bigger in proportion than the rest of the body. So as you can see in the picture here, when a child lays flat, that head will shove that chin down, causing possibly airway obstructions. So any little kid that you have, you need a pad under the torso, under those shoulder blades, so then that way it'll get the torso up, therein getting the head elevated as well. As well as that head being much larger in proportion than the rest of the body, there's numerous other upper airway differences. The child has a smaller nose and mouth, so that tongue is relatively the same size in a kid as it is an adult. So with that smaller mouth and a larger tongue, that tongue occupies a whole lot of space. So that tongue can be a major obstruction to the upper airway. So remember, in every patient, the tongue is the #1 obstruction of the airway, especially in kids. So in that big head, if the torso is not padded, the head's forward, the tongue relaxes back, obstructing that airway. And with the kids having that smaller nose, it's easy to obstruct as well, getting just mucus and snot and things like that in the nose. A little bit of stuff like that in an adult, not a big deal. It gives us a bit of stuffy nose. Little kids can completely block their nasal airway. The kid's trach is more narrow and it's less rigid. So think about this. The vacuum cleaner hoses you see, on Grandma's old vacuum cleaner, he had a handle on the bag behind it. Well, all his vacuum cleaner hoses have a strong rings around it so it doesn't pinch or crink. So that's just kind of the same way as a kid's trachea. In adults, they're really strong, rigid, got a lot of real strong rings in it so that they don't bind or pinch. Whereas a kid's, it's more like a soft rubber hose, so that bending of the neck can completely close that trachea, completely closing off the airway. And with that being soft too, more easily obstructed from choking, things like that. Also, their ribs are a lot more box-like, whereas adults, they're more rounded. Those kids kind of got little squared chests, and also the ribs are more cartilage than they are bone, so they have have a limited ability to take in those deeper breaths because the adults, their ribs can open up and flex more than those neonates. They're just little cartilage box-like shapes, or cartilage box-like shapes. So that chest is a little bit different to open up. So as I said before, since they are nose breathers, make sure you have to suction out their nose. So you've probably seen parents before, those little blue ball snot suckers sucking out the kids' noses. It's very important to ensure a patent airway in that child. So with that chest of the child being elastic because his ribs haven't formed into solid bones yet, they're a lot of cartilage. There's a lot less protection there for those organs. So you remember in adults, all the important organs are tucked up underneath that rib cage, so it's kind of like that roll cage for all the really important organs. In the child, those aren't nearly as rigid, they're elastic, so a lot less protection there. And also, those kids are abdominal breathers or belly breathers, as you hear. And that's because they don't have that fully developed chest yet. They don't have abdominal muscles. So all you can see is that diaphragm working really hard, moving back and forth to be pulling air in. And with their body surface, just like the head is large in proportion to the rest of the body, that the body surface is larger than adults in proportion to the mass. So the kids are kind of like a really big house that has a really old little furnace. So temperature regulation is oftentimes very hard in the kids. So the kids are very vulnerable to hypothermia. So when you go outside and it's winter and you got a short sleeve shirt on checking the mail and you're like, oh man, it's not too bad, just a little cold. You do it to a kid, it's like, holy crap, oh my god, I'm froze to death really fast. So they will unregulate their temperature very quick. So with us adults, you can be outside and be cold for a good while and your body can compensate, whereas the little kids, not so much. They get exposed to cold weather, they get cold very fast. And also with that blood volume, another reason that it's hard for them to stay warm is they don't have a whole lot of blood volume in the body. So think about this, a 9-pound newborn has about as much blood as what's in 1 can of soda or pop, whatever you want to say. Whereas the child, say 60-pound kid, got about 2 liters of blood. So think about going from a 12-ounce can of soda to a 2-liter soda, to where an adult has about 4 to 6 liters depending on their size and their mass. So your average 125-pound adult, about 2 liters of soda, or you got 200-pound adult, it's going to be up around the 6 liters. So when it comes time to interacting with that pediatric patient, identify yourself, let them know who you are, because they may not understand and recognize uniforms. Let them know that somebody has called the parents if the parents are not around, and interact with them. Get down at the child's eye level. Don't stand up high, mighty, and intimidate the kid with your arms crossed. Interact with them, play with them, build some rapport with the kids. Give them a toy, give them something to play, give them a pen light, let them shine it in your eye. And also the most important thing is to remain calm. Children can sense that. If you've ever seen kids around people who are upset, a kid will just cry by proxy. If they see somebody else cry, they're probably just going to cry. So if you're not calm, you're not going to make mom calm, and then it's just going to be a cascading effect and the baby's going to be upset. But if you're going to be there in charge of the scene and you're remaining calm, it will be contagious. Your calm demeanor will spread to everybody else, the parents, bystanders, everything, and help calm that patient. So just smile, interact with him, touch their hands, tickle their feet, build up some rapport with them, make them comfortable with you, because a lot of these kids are going to have a stranger danger complex no matter what kind of uniform you have on. If you're going to be listening to their lungs, kind of explain to them what you're going to be doing. Tell them step by step everything you're doing, because they're going to be freaked out. This may have been their, they haven't been to a doctor in quite a while and they don't really know who you are, what you're doing, what's going on. So explain yourself, what you're doing, and they'll be curious. So you can let them see the equipment, play with it if you want to. If you're listening to lung sounds after you do it, granted, if the kid's stable, let them put on the stethoscope, listen to your lungs, just let them play, interact, and it will keep the patient and the whole scene a lot more calm. And also, never lie to the kid. Kids can see right through lies. It's like a special sense of theirs. Do not lie to the kid, because they will remember that forever. With the adolescents, a little bit different than the kids, because at this point they should be able to tell you exactly what's wrong. You're not going to do a whole lot of detective work trying to figure out what's happening. They may not be able to completely communicate in front of their parents. If the kid's acting a little bit weird and you suspect that they've drank something, they're not going to want to admit that in front of the parents. So if you get the kids away from the parents, they'll open up to you like Pandora's box. They'll tell you all their dirty secrets, generally everything, as long as you have that good rapport with them and let them know you're not going to be the one to get them in trouble and everything like that. So, and also sometimes if you have the kids that are right at the puberty stages, they're going to feel embarrassed or awkward about exposing themselves. So trying to use care providers of the same sex. So if you are a male EMT and you have a female that you need to take, say trauma, whatever, that you need to expose them, ask them some really personal questions. If you have a female partner, maybe have her be the one to do that. Also, on that same note, if you have any young kids and you have to expose them to stuff, it's always good to have another partner or somebody in the back with you, just to kind of keep an eye on everything that's going on, as to kind of be your witness and to have your back and justifying of what you're doing is appropriate. Don't delay care because the patient may be embarrassed. If you need to derobe a patient because of trauma, whatever related things going on, you're just going to have to do it and tell them that you have to do it for their safety, whatever. Don't be like, well, I don't think I need a cuff or close. They're really uncomfortable with it. I don't know if they're bleeding or if they're really hurt, but I'm just going to leave them. Don't do that. It's utmost, the care is the number one important thing. And I've said before, if you have to do things like that, they're going to make the patient feel a little awkward. Try to have that done by the same sex partner as your patient, or at least have a partner with you while you're doing those things, so you can essentially have a witness. One of the toughest things about pediatric calls is the emotions that tie into it. So a big part of that is you're going to have to provide some support, possibly to your partners and other care providers, as well as the parents. So supporting the parents, they can be in denial, shock, crying, just going nuts because their baby is hurt or sick. And a lot of times they're just overreacting. They think that something is crazy wrong, and a lot of times it's something really simple. But on the other hand, it can be the same other way. They can underplay it, thinking that nothing is wrong, that maybe the kid's just really sleepy and the kid is really, really hurt. So this could interfere with care of that child when you got mom that's screaming, going nuts, and she won't let go of the baby. Then also remember to don't be subjective or opinionated on this, because not all kids live in that traditional nuclear family. By that it means that it's not always a mom and a dad and the happy family. Times are changing, so that could be that you've got a mom and a kid, or a dad and a kid, or a dad and a kid, or just a mom and a kid. There's a variety of things. So don't be so opinionated by that, and kind of tailor your questions too. If you're asking about the family, don't say, hey, where's your dad at? And the kid's like, oh my God, my dad left 5 years ago, blah, blah. So just kind of keep that in the back of your mind when you're asking questions, that if a parent isn't there immediately, they may not always be there immediately. And then comfort the child. Little ones, they may wrap up you in comfort, or allow the parents to be there too to help provide emotional support to them. But remember, you got to try to keep the parents calm if you're going to be having them to help try to keep the patient calm. So now we'll move on to talking of assessing that pediatric patient. So you're going to have two viewpoints. This can be from the doorway, and then you're going to have the patient. So from the doorway, that's where you're going to get your general appearance. So before you can touch them, do anything, just using those senses of your vision, sights, sounds, so on. So you're going to use a pediatric assessment triangle, and the components of that is the appearance, worker breathing, and circulation of skin. So you see in the part of appearance is tone. Kind of how are they sitting? Are they lethargic? Are they slumped over? Are they able to hold themselves up well? Interactiveness, when they see you, are they making eye contact with you? Do they notice you moving around, or are they just having that weird look and a gaze, just staring off? Or if you ask them to grab your hands, do they follow commands? How do they just act? The consolability, when mom picks up the kid and is crying, is it able to calm the kid down at all? And speech and cry, are they able to talk? Should they be able to talk? Are they crying? Remember, a crying kid, that means that's a patent airway. Next is that work of breathing. Do you hear any weird breath sounds without even using your stethoscope? So from that door, do you hear any stridor? Do you see any abnormal positioning of the body? Are they doing the head bob, trying to get that breath in? Do you see any intercostal muscle retractions? The muscles in between their ribs where they're trying to suck in as much air as they can, so his muscles are pulling really hard. Are they doing nasal flaring? Are they trying to suck air through their nose so hard that it's making their nostrils flare? And then a circulation of the skin. Do you notice any pallor, meaning pale color of the skin, any mottling, where the skin will just kind of be red and splotchy? Do you see any cyanosis, any bluing of the skin? So with that general impression, that's going to help you rapidly identify a critical patient. So also things you need to make note of is that mental status, the interaction, and their emotional state. Remember, with assessing of the mental status, a mnemonic of AVPU, alert, verbal, painful, and if they don't meet any of those, they are unresponsive. So with pain, you're not taking your knuckles and rubbing them into the sternum of this child. You're going to gently tap them on the chest or on the feet. When assessing the airway, see and make sure that the airway is open and patent. And if you open the airway with a head tilt, chin lift, or jaw thrust, be careful not to hyperextend that child's fragile neck. So assessing the airway and their breathing. So after you've checked the mental status, checking the airway and their breathing, so looking at the face, checking that appearance, work of breathing and circulation. Do you hear any crazy sounds? Do you see any flared nostrils? Do you see any kind of pale or bluish lips around the mouth? Do you see any cyanosis? Do you hear any of those crazy sounds? So using that whole head of the mental status, checking their nose, see anything there, anything at the mouth, how's the work of breathing, any kind of crazy colors, and do you hear any weird sounds coming out of the mouth? Then for breathing, is a rate greater than 60? A breathing rate in any kid greater than 60 is bad. Do you see any accessory muscle use? Do you see the muscles around the neck being used? Any retractions of those intercostal muscles? Do you see just any kind of more body positioning, any other work from the body going into it besides just the normal rise and fall of the chest? Do you see any decreased muscle tone? Are they coming kind of limp and very lethargic? Any more poor peripheral perfusion, checking pulses and capillary refill? So when you're assessing that circulation, you want to check for and hopefully find that warm, pink, and dry skin and good pulses. And checking that capillary refill in all pediatrics, especially those 5 years or younger. So to check for capillary refill, I'm sure most of you have probably done this to check if you're sunburnt. You just push down on the skin where it's pink and you'll see your fingerprint turn white. Then you want to be able to see that skin go back to pink within 2 seconds. So that is your capillary beds that you're checking of how long it takes to restore blood to those capillary beds. If it's taken longer than 2 seconds, that means they have some perfusion issues, that it's taking too long for the blood to get back to those capillary beds. And assessing and identifying any priority patients. A priority patient in a kid is any abnormality you may find to that pediatric assessment triangle of any change in appearance, any increased work of breathing, or any changes in the circulation of skin. Then moving on to the physical exam. With the physical exam, start at the toes and work away to the head. If there's no injuries, the parent can go ahead and hold on to the kid on the cot. Not a big deal. It's another way to help keep that kid calm and protect that child's modesty. If you're having to derobe them to be checking the things, Keep that in mind. Maybe if you have to derobe them, cover them back up and make them feel secure and safe, and explaining every procedure that you do. With the extremities, check capillary refill in all extremities, checking for pulses and the motor and sensory. Can you wiggle? Can you feel? Tickle those kids' feet, see if they retract and curl their toes. Moving on to the pelvis. At the pelvis, you're checking for stability of the girdle. So you'll just kind of do a press and a squeeze on it, not real hard, just to make sure that there is no pain there and no grimace. So as you squeeze on that hip, look at the kid's face too to make sure they don't wince or appear to be in any kind of pain. Abdomen, make a note if it's rigid and go on. Check for tender areas, any kind of distension, because any kind of injury to them, since most kids are abdominal breathers, any abdominal injury can impede the movement of that diaphragm, causing them to have some respiratory issues. Looking at the chest, being alert for wheezing or any other kind of advantageous sounds. Checking for symmetry, equal rise and fall of the chest, see if there's any bruising from any kind of chest trauma, and checking for paradoxial motion and retraction. So with that airway, as you see in the picture here, the head's up in a nice neutral position because that torso is padded. So maintaining that neutral position and that sniffing position for the kids. If there's no suspicion of spinal injury, just take a flat folded towel or a sheet, something to place under that torso when they're laying on their back. So moving on to the nose and the ears, looking for any blood or clear fluids coming out of the nose and ears. If you see any kind of blood or fluid coming out of the nose and ears after a traumatic injury, suspect a skull fracture. Also, remember keeping that nose clean. Any kind of mucus or clot can obstruct that airway drastically. If you're going to give them oxygen, one of the best ways to give kids oxygen is blow by. So you can just use oxygen tubing to blow it across the kid's mouth. Don't blow oxygen into their eyeballs. Oxygen can dry out those mucous membranes, so it'll dry out their eyes and can make a kid go blind. So just do blow by oxygen. That neck is very susceptible to spinal cord injuries. It's just a little thing, it's not real sturdy yet. So if you see kids as they get a little bit bigger, they've got that big bobblehead, it's because their neck hasn't really developed into its good structure yet, and not a lot of good muscles, so not a lot of protective mechanisms there. And they got those great big old bobble heads because they're so much bigger proportionally than the rest of the body. So at the head, don't apply pressure to those fontanelles. If you see bulging coming out of that fontanelle, don't try to push it back in. Meningitis and head trauma can cause bulging of those fontanelles. And also dehydration can cause sinking of the fontanelles. You will reassess the unstable patient every 5 minutes, or the stable patient about every 15 minutes. Keeping notes of any mental status changes, monitoring their airway and their breathing, monitoring that the circulation with skin color, temperature, and moisture, as well as the circulation and capillary refill, and ensure that all appropriate care and treatments being given. So sometimes you may not be able to do complete reassessments because of your interventions that are necessary. Now we'll talk about some special concerns with pediatric. When using an OPA in the adult, you put it in upside down. As you put it in, you twist it. But with children, you must put the OPA in the way it will align. So use a tongue depressor, some way to depress that tongue, and put the OPA in straight. If you put it in and try to turn it, you could possibly cut that sensitive part of the infant's mouth, causing bleeding, therein causing an airway obstruction. So use something to depress the tongue and put the airway in. With nasopharyngeal airways, be sure that you still have that head positioned appropriately to keep that airway patent in the sniffing position. So clearing out an airway obstruction, there's some partial obstructions and complete obstructions. With a partial obstruction, if they're able to cough and talk, just let them keep trying to cough and hack, give oxygen, and then transport them in a position of comfort. With a complete obstruction, you need to perform airway clearance techniques. So hold them upside down, not completely upside down, so don't grab them by their ankles and shake them, but get the head below the butt so that gravity's a little bit of your friend, and do 5 back slaps, then rotate with 5 compressions, and then keep assessing the airway. If as you turn them over and you look at the airway, if you see something, scoop it out. Just don't go stick your finger in a kid's mouth trying to look for something. So when giving oxygen, give it to those in respiratory distress, those have inadequate respirations, and those that are possibly in shock. Preferred method is via blow-by with a non-rebreather mask. Or as I said before, you can use that oxygen tubing just to blow it past their nose and their mouth. Don't strap a non-rebreather to their head and be blowing oxygen into their eyes and everywhere else. Just blow-by oxygen. If you have to ventilate them, avoid breathing too hard so you don't pop them like a balloon. Be careful of using excessive pressure and volume. A lot of pediatric bag valve masks now will have a PEEP valve on it, to where if you go to squeeze it too hard, the valve will blow off because it knows and senses too much pressure in there. So keep an eye on that and make sure you know what kind of equipment you're using. And use properly sized face masks to ensure good. A properly sized mask should fit right at the bridge of their nose to below their mouth. So if you have to use a bag valve mask or you're going to use a pocket mask, be sure you're using one of appropriate size. Also, oxygen powered ventilation devices are contraindicated in infants and children. This being an example of CPAP. You cannot put CPAP on a baby. It will pop their lungs. If ventilation is not successful, to raise their chest, try to see if there's an airway obstruction. So if you find a kid in respiratory arrest and you're bagging them and it's not working, don't keep trying to squeeze a bunch of pressure down in there. Perform airway obstruction procedures.